X-ray of the chest. The first step in reading an X-ray film is to hold it correctly, upright and with the letter R on your left side, as if the patient is standing facing you. Then confirm that it is well centralized and well exposed. In a well centralized film, the medial ends of both clavicles are equidistant from the spine. If they are not, then you cannot make any comment on the mediastinal shift, cardiomegaly, or on comparative radiolucency of the lung fields. In a well exposed film, the spinous processes of only the first four thoracic vertebrae are seen. Others are hidden by the heart shadow. If the film is overexposed, more vertebrae are seen and the lungs appear more translucent. Now first study the lung fields in the three zones, upper, middle and lower. Upper zone is the area above the anterior end of the second rib. Lower zone is the area below the anterior end of the fourth rib. And middle zone is between the anterior ends of the second and fourth ribs. Compare the lung fields on the right and left side in the upper, middle and lower zones. The lung fields should be equally radiolucent on both sides at equivalent levels. Now study the apices very carefully, especially the area just behind the clavicles where the earliest tuberculous lesions are found. If there is a bony asymmetry, look for a cervical rib. Then inspect the cardiophrenic and costophrenic angles. They should be sharply defined. Any obliteration of any of these angles is pathological. The right diaphragm should be 0.5 to 1.5 centimeters higher than the left diaphragm, and both should be smoothly curved. Then study the hyla, represented by the shadows of the hilar vessels. The left hilum is normally at a slightly higher level than the right. Lastly, identify the course of the trachea up to the carina for any deviation. This completes the inspection of the lung fields. Now inspect the cardiac silhouette. First study the cardiac border and measure the cardiothoracic ratio for cardiac enlargement. The left cardiac border is made of aorta, pulmonary conus, left atrial appendage and the left ventricle. The right cardiac border is composed of superior vena cava and the right atrium. We will study the details later. To measure the cardiothoracic ratio, draw a vertical line through the center of the spine. Draw lines A and B perpendicular from this line to the maximum widths of the right and left heart borders. A plus B gives the maximum transverse diameter of the heart. It should be less than half of the maximum transverse diameter of the chest, that is C, that is the transverse line joining the inner borders of the ribs at the widest portion of the chest. We will study the details of the heart shadow in a later section. After studying the lung fields and the heart, inspect the bones. First the ribs for crowding, spreading and bony lesions, then the clavicles, scapula and shoulder joints. Lastly, study the soft tissues, the muscles, the subcutaneous tissues of the chest and the neck, and in females, the breasts. After studying all these minute details, it is very important to stand at a distance and look at the film as a whole, because many times a close and minute inspection may miss a gross change. And then hold the film at an angle and view it slightly tangentially. Minor changes in radiolucency of the lungs are better appreciated this way. This completes the study of an X-ray of the chest. Over the years, with experience, you become so familiar with the normal structures that a change will be recognized at a glance. But a good practitioner will never call an X-ray as normal at a glance. Even the most experienced radiologist will study the film systematically and minutely before giving his opinion. We will study the X-ray lesions of tuberculosis under three headings: the parenchymal lesions, the pleural lesions and the primary complex. The characteristic lesion of early tuberculosis is infiltration. It is a soft, fluffy opacity like spread out cotton with tiny opacities merging into each other, interspersed with streak-like shadows. Tuberculosis most commonly starts in the apical and posterior segments of the upper lobe. So the early lesions are often seen behind the outer part of the clavicle. This is a typical early lesion of pulmonary tuberculosis. Note the fluffy nodular opacity behind the right clavicle. This is another early lesion in the right upper zone, appreciated better if you compare it with the apex of the opposite side. In a close-up view, note the cotton-like fluffy opacity. This X-ray shows an infiltration of the left upper zone in an early case of tuberculosis. The close-up shows tiny white opacities merging into each other scattered in the left upper zone. This X-ray shows bilateral early infiltration. Note the shadow of the infiltration in right upper zone and the left middle zone. The second characteristic lesion in tuberculosis is a cavity, seen as a circular radiolucent area usually in the apical zone. This is a typical tuberculous cavity. It is thick-walled, circular, radiolucent area and is situated in the upper zone. The wall is smooth and there is no fluid in it. Note the surrounding infiltration, which is almost always seen around a tuberculous cavity. So this is a typical cavity in tuberculosis. In this X-ray, there is a cavity in the left, mid and upper zone. It is a very thin-walled cavity and is seen only on close inspection as a radiolucent area without lung markings. This X-ray shows a large cavity in the right upper zone. Note the smooth and thick wall indicating that it is chronic and the surrounding infiltration in the upper lobe. This is a typical tuberculous cavity. This X-ray shows a thick-walled cavity in the right mid-zone, but note that the wall is smooth and of even thickness and there is no fluid level. This X-ray shows a cavity in the left upper zone in a collapsed and fibrosed left lung. The mediastinum is pulled to the left side and the cavity is seen clearly within the fibrosed lung. Sometimes a typical tuberculous cavity shows a rounded opacity within it. Note this opacity in the left upper zone cavity. It is rounded and lying freely mobile within the cavity. This is a fungal ball. It is caused by superadded fungal infection, usually aspergillosis. Note the fungal ball within the tuberculous cavity. Sometimes cavities can occur in atypical locations. This is a cavity in the lower zone. Note the thick but smooth wall, absence of fluid level and surrounding infiltration. This is a large and irregular cavity in the left lower zone. In a close-up view, note the thick and irregular wall. Lower zone cavities and atypical cavities are seen in patients with diabetes and HIV infections. The next typical change in healing tuberculosis is fibrosis. Fibrosis appears as opaque linear streaks radiating towards the hilum of the lung. The shadow of fibrosis as compared to infiltration is more dense and sharply delineated, and the neighboring structures like trachea or diaphragm are pulled towards it. Note a typical shadow of fibrosis in the left upper lobe. Note that it is denser than infiltration with opaque streaks radiating towards the hilum. The trachea is only minimally pulled towards the lesion. This X-ray shows fibrosis in the right upper lobe. Now we will see the shadow of the trachea and see how it is pulled towards the lesion. Fibrosis in the lung tissue causes a contraction and reduction in the size of the affected lobe and pulls the neighboring structures towards it. Here we see that the upper mediastinum is pulled. This is another case of fibrosis in the left upper lobe. Note the tracheal deviation towards the fibrosis. In close-up view, note how the trachea is curved. If for some reason trachea and the mediastinum are fixed, then the diaphragm will be pulled up by fibrosis. In this X-ray, there is left upper zone fibrosis. The trachea is central, but note that the left diaphragm is pulled up. Normally, left diaphragm should be at a lower level than the right. So, either the mediastinum or the diaphragm or both may get pulled towards a fibrotic lung. This X-ray shows very dense fibrosis in the right upper lobe, and it has pulled all the structures towards it. The trachea is pulled to the right, and the transverse fissure and the diaphragm are pulled up. In this X-ray, with extensive fibrosis on the right side, inspect the other lung, that's the left lung. It is hypertranslucent, bigger, with low diaphragms. The lung markings are diminished. This is a compensatory emphysema on the opposite side to compensate for the fibrosed lung. When fibrosis occurs close to the diaphragm may become tented. If the diaphragm is pulled up at one point, it gets raised with a sharp angle. This is termed as tenting of the diaphragm. Note the typical angulated tent-like appearance. In our country, very often, the tuberculous lesion is more advanced, more extensive, and is seen as a combination of fibrosis, infiltration and cavitation, termed as fibrocavitatory lesion. Note the thick-walled cavity and fibrosis in the right lower zone, a large thin-walled cavity in the mid-zone, and another small thick-walled cavity in the upper zone with extensive fibrosis. This is another X-ray showing bilateral fibrocavitatory lesions. Note the dense shadow of fibrosis on the right side combined with cavitation in the left upper lobe. This is an X-ray of fibrocavitatory lesion on the right side with compensatory emphysema on the left. Note the multiple cavities and fibrosis in the right upper zone with trachea pulled towards the lesion due to fibrosis, while the opposite lung is hypertranslucent due to compensatory emphysema. This X-ray shows a fibrocavitatory lesion in the mid-zones. Note the dense streak-like shadows of fibrosis with cavities in between. In this X-ray, we see advanced fibrocavitatory lesions on both the sides. Note the very dense and sharply defined shadows of fibrosis on both sides, and on the left side, amidst the fibrosis, the arrow points to one of the small thick-walled cavities. Another type of picture in tuberculosis is miliary tuberculosis, which occurs when there is an overwhelming infection. Note the fine, pinpoint, soft opacities which are spread uniformly throughout both the lung fields. Each opacity is about 2 millimeters in size. Also note that the opacities do not coalesce. They are individually separate and discrete and are fairly equal in size. This is miliary tuberculosis. This is another X-ray of miliary tuberculosis. Note the fine pinpoint mottling spread uniformly in both the lungs. Once again, note that the opacities are fairly uniform in size and they are separate from each other. For comparison, this is non-miliary mottling. Note that the opacities are larger in size, varying in size, and their distribution is not uniform. They tend to coalesce to form larger opacities. Now compare the two, the fine uniform mottling of miliary tuberculosis in the inset and the irregularly distributed opacities of varying size in other conditions. Healing in tuberculosis occurs by fibrosis and calcification. So healed lesions leave their marks in the form of fibrosis or calcified spots. This X-ray shows calcifications in both lungs. Note the density of these lesions. They are denser than the bones. These are calcifications in old tuberculous lesions. This X-ray shows calcified lesions in the left upper zone and right hilum, indicating old healed tuberculosis. Note that the density is more than the bone density. Calcifications near the hilum are usually calcified hilar lymph nodes, and peripheral calcifications are due to calcified foci of caseation. This X-ray shows extensive fibrosis in the right lung with shift of trachea to the right, and the left lung with compensatory emphysema shows dense specks of calcification. This is another healed lesion showing calcific spots in both lung fields. Note the dense white spots indicating calcified areas of caseation. Now inspect this lesion carefully. The left upper zone shows infiltration as well as some calcified spots. Let us see in close-up. The dense calcified opacities indicate old healed lesions of the past, but the cotton-like fluffy infiltration indicates a fresh lesion, probably reactivation of old lesion or reinfection. Now we will see some advanced lesions. This X-ray shows extensive bilateral lesions, the right lung showing extensive infiltration and fibrosis and a small cavity in the mid-zone. This X-ray shows infiltration on the right side in the right upper and mid zones with a cavity in the upper zone. The left mid zone shows early infiltration. This X-ray of the same patient at a later date shows denser opacities of fibrocaseous lesions in the right upper and mid zone, and note the cavity in the midst of the fibrosed lesion. This X-ray shows an extensive infiltration of the left upper and mid zones with small cavities and a few patchy infiltrations in the right mid zone. This X-ray shows extensive fibrosis in both the lungs with compensatory emphysema in the lower zones. Now before we move to the pleural lesions, let us see some tuberculous lesions and the effect of treatment on them. This is the first X-ray before starting chemotherapy, showing extensive lesions involving both the lungs. Note the fluffy appearance of infiltration. This is the second X-ray after 5 months. Now the lesions are more sharply defined and fibrotic, and infiltration shadows have reduced. And the last X-ray after 1 year of chemotherapy shows complete healing with minimal residual fibrosis. Now let us see in close-up the right mid-zone of the same X-ray. Note the infiltration in the first X-ray. Then note the fibrosis and resolving infiltration in the second X-ray after 5 months, and the fine fibrotic streaks in the final X-ray. This is another patient showing a dense infiltration in the right upper zone. The second X-ray after 1 year of chemotherapy shows complete healing with only a few fibrotic streaks in the upper zone. Let us view it in a close-up view. Note the dense infiltration involving the right apex. The second X-ray shows just a few thin fibrous streaks and slight shift of trachea towards the lesion indicating fibrosis. Note this X-ray showing infiltration in the right mid-zone and the left upper zone on detection. After completion of treatment, the right mid-zone shows residual fibrosis, while the left upper zone has healed without trace. Now we will come to the pleural lesions. Presence of fluid in the pleural cavity is termed as pleural effusion, which is a primary tuberculous infection. Pleural effusion. A mild or minimal effusion causes blunting of the costophrenic angle, which is the earliest sign of a developing pleural effusion. A moderate effusion produces uniformly opaque shadow in the lower zone, which typically rises in the axilla. It also displaces the mediastinum towards the opposite side. A massive pleural effusion produces complete or almost complete opacity of the affected side and a marked shift of the mediastinum to the opposite side. This is a typical X-ray of a moderate-sized pleural effusion. Note the homogeneous opacity of the right lower zone with a concave upper border which is well defined but not sharp, rising higher on the lateral side towards the axilla. This is a characteristic appearance in pleural effusion. In this X-ray, we see a minimal pleural effusion seen as an obliteration or blunting of the left costophrenic angle. A minimum of 250 to 300 ml of free fluid is required to produce this minimal shadow in the routinely taken anteroposterior film of the chest. Compare it with the right costophrenic angle, which is sharply defined. This is another X-ray showing blunting of the right costophrenic angle. Note the haziness filling the angle. Comparison with the opposite costophrenic angle will make these minor changes more apparent. So blunting or opacity of the costophrenic angle is the earliest change in a pleural effusion. This is another X-ray of a moderately large pleural effusion. Note the homogeneous opacity with the concave upper border, and note that the mediastinum has shifted to the opposite side. Of course, if the mediastinum is not mobile, then mediastinal shift may not be present even if the effusion is large. This is another X-ray of a moderately large pleural effusion. Note the homogeneous opacity in the right lower zone with concave upper border rising in the axilla and the shift of the heart to the opposite side. So the features of a pleural effusion are blunting of the costophrenic angle, homogeneous opacity with a concave upper border which rises on the lateral side, and shift of mediastinum to the opposite side. This now is a very massive effusion with complete opacity of the right side and shift of mediastinum to the opposite side. Note the shift of the heart to the left side. When the opacity is complete and concave upper border is not seen, then shift of mediastinum to the opposite side is very suggestive of a pleural effusion. This X-ray shows a massive effusion on the left side. The concave upper border is not seen as the fluid is completely filling the left chest. Note the tremendous shift of mediastinum that the fluid has caused, pushing the heart to the right side. This is a typical massive pleural effusion. Now this is a set of two X-rays of a patient of right pleural effusion before and after aspiration. This is a very typical shadow of pleural effusion. And this second X-ray after aspiration shows that the fluid is removed, the lung has expanded, the costophrenic angle is clear, and there is a diffuse thin haziness in the right lower zone, which is due to the pleural reaction or inflammation. This is another set of X-rays before and after pleural fluid aspiration. Note the right pleural effusion. The second X-ray after fluid aspiration shows the pleural reaction as haziness in the right costophrenic angle. And the third X-ray after 2 months of chemotherapy shows a completely clear lung field. Now in this X-ray, there is a homogeneous fluid opacity with a smooth curved border, but it has not concave but convex border. This is an encysted pleural effusion where the fluid is loculated due to pleural adhesions. The opacity is peripheral and its convex border is towards the lung. This is characteristic of an encysted or a loculated pleural effusion. This is another opaque peripheral shadow with convexity towards the lung, which was an encysted pleural effusion. A similar shadow may be seen with a cold abscess arising from the ribs or an extrapleural mass. An ultrasonography is helpful in confirming the diagnosis and in localization of the point for aspiration of the fluid. Sometimes an encysted effusion lies in the right interlobar fissure and produces a shadow between the 4th and 6th ribs anteriorly. And in a lateral view, a characteristic elliptical shadow of the fluid is seen, extending from the 5th thoracic vertebra behind to meet the diaphragm anteriorly 4 centimeters behind the sternum. Sometimes the fluid gets collected under the lower surface of the lung, between the lung and the diaphragm, and remains convex upwards. Note in this X-ray that the right diaphragm appears to be elevated with preservation of the costophrenic angle. This is termed as a subpulmonic effusion, an effusion under the lung. After aspiration of fluid, the true diaphragm is seen and the lower lobe of the lung has expanded. Let us compare the level of the diaphragm in the two pictures. The inner X-ray before aspiration shows the raised hemidiaphragm. A similar appearance may be seen in subphrenic abscess and diaphragmatic paralysis. Pneumothorax. Pneumothorax is a collection of air in the pleural cavity. It produces a partial collapse of the lung and is seen as a uniformly black peripheral shadow outside the lung border with absence of vascular markings. When large, it produces a complete collapse of the lung and shift of mediastinum to the opposite side. Note the collapsed right lung, which gets collected as a radio-opaque shadow at the hilum in massive pneumothorax. In this X-ray, note the peripheral radiolucent area on the left side with no bronchovascular markings. This uniformly black area represents a collection of air in the pleural cavity or pneumothorax. The lung is collapsed and you can see that it is more radio-opaque and its border is seen as a thin white line demarcating the collapsed lung. Note in the close-up view the absence of bronchovascular markings over the pneumothorax and the sharp border separating it from the lung. Now in this view, compare the normal lung on the right side with pneumothorax on the left side. Absence of bronchovascular markings is better appreciated when compared with the normal lung on the opposite side. This is another X-ray showing air in the right pleural cavity without significant shift of mediastinum. Note the peripheral radiolucent area on the right side and the thin line of lung border representing the visceral pleura, which demarcates the collapsed lung from the air. Note the absence of lung markings in the dark radiolucent area. Now this is a set of two X-rays. The first X-ray shows left pneumothorax. Note the radiolucent peripheral zone along the chest wall and the apex. The costophrenic angle is clear, indicating that there is no associated fluid or pus in the pleural cavity. Now this second X-ray shows the picture after aspiration of air. The lung has expanded and the bronchovascular markings are seen up to the chest wall. The lung does not show any lesion, infiltration or emphysematous bulla. Such spontaneous pneumothorax occurs due to a subpleural tuberculous focus. This is another case of pneumothorax in a child. Note the radiolucent shadow around the right lung. The lung border is sharply defined and the lung itself shows uniform opaque shadow suggestive of associated consolidation. If the pneumothorax is very small or not seen clearly, then the X-ray should be repeated in full expiration when pneumothorax is demonstrated more clearly. If the pneumothorax is traumatic, you should look for rib fractures and inspect the subcutaneous tissues for surgical emphysema. In this X-ray, note the pneumothorax on the right side and note the air in the subcutaneous tissues shown by the black arrows. The air in the subcutaneous tissues is termed as subcutaneous emphysema. The black arrow shows the air delineating the subcutaneous tissues and the muscles. And the white arrow marks the lung border, lateral to which is the radiolucent shadow of pneumothorax. Now a careful inspection of all the ribs will reveal a rib fracture which has caused the pleural injury and air leak. In this X-ray, the radiolucent shadow is seen only in the lower zone. It does not extend to the apex. This is an encysted pneumothorax. The air in the pleural cavity is loculated due to pleural adhesions. Note the well-defined sharp border and compression of the adjoining lung tissue. If the border of an encysted pneumothorax is very thin, then it is difficult to differentiate it from an emphysematous bulla. A bulla has very thin borders and it does not compress the adjoining lung tissue as seen here. This is a massive pneumothorax on the right side with total collapse of the right lung and the mediastinal shift to the opposite side. Note the complete radiolucency on the right side with collapsed lung at the hilum. Since the lung is completely collapsed and airless, it has become white or opaque and it occupies only a small area near the hilum. Any pneumothorax which occupies more than one-third of the hemithorax needs to be drained using an intercostal tube. This is another case of a complete pneumothorax. The left hemithorax is radiolucent and the mediastinum is markedly pushed to the opposite side, compressing the right lung. The large amount of shift of mediastinum is indicative of the high pressure in the pneumothorax, and this is termed as a tension pneumothorax. A tension pneumothorax is a medical emergency requiring urgent drainage as it is compressing the opposite lung and hampering with its expansion. This is one more X-ray of tension pneumothorax. Note the radiolucency over the entire left hemithorax, complete collapse of the left lung, and signs of high pressure in the left pleural sac. That is, the mediastinum is shifted to the opposite side, compressing the opposite lung. The diaphragm is pushed downwards and flattened, and the intercostal spaces are wider. This is tension pneumothorax. This is another X-ray of tension pneumothorax. Note the complete radiolucency of the right hemithorax with shift of mediastinum to the opposite side. The diaphragm is pushed down to a level lower than the left diaphragm and intercostal spaces are widened. Hydro and pyeopneumothorax. When pleural cavity contains both fluid and air, the condition is termed as hydropneumothorax if the fluid is clear and pyeopneumothorax if the fluid is pus. This X-ray shows a horizontal fluid level in the right hemithorax which is touching the chest wall laterally. The red arrow shows the horizontal fluid level and the yellow arrow shows the border of the collapsed lung seen parallel to the chest wall, separated from it by the radiolucent band of pneumothorax. These two lines mark the hydropneumothorax. Now inspect the peripheral zone. Above the fluid level, we see the peripheral band of radiolucency due to air, and below it is the opacity due to the fluid. This is hydropneumothorax. This is another X-ray showing hydropneumothorax on the left side. Note the fluid level, the air above it, and the collapsed lung. In the close-up view, the red arrow shows the fluid level and yellow arrow shows the collapsed lung border. Whenever there is a horizontal fluid level with pneumothorax and lung collapse, it is a hydropneumothorax or a pyeopneumothorax. Now, how to make out whether the fluid is pus or a simple serous fluid? It is not possible to distinguish it so with certainty, but suspect a pyeopneumothorax if the ribs cannot be seen through the fluid and if the lung border shows a lot of fibrosis. In the first X-ray that we saw, we can see the ribs through the fluid and the lung border is thin, so it is definitely a hydropneumothorax. In the second X-ray, the ribs cannot be seen through the fluid, and though the lung border is not much thickened, it is more likely to be a pyeopneumothorax. In this X-ray, note the loculated fluid collection on the left side with an air fluid level. The fluid appears to be pus as ribs cannot be seen through them, and note the marked thickening of the lung border. So this is loculated pyeopneumothorax. Compare it with this X-ray of loculated hydropneumothorax. Note the lung border shown by the yellow arrow which is not fibrosed. On aspiration, clear fluid and air were aspirated. And in the next X-ray, you will see that the lung has expanded well with only a thin rim of air and small amount of fluid at the bottom. Now here we see a fluid level on the right side with air and the lung border, but only in the lower part. The air is not extending to the apex. This is loculated pneumothorax. The thick lung border suggests that it is a pneumothorax. Note in this X-ray of loculated pneumothorax that the ribs are not seen through the fluid, and note the thick fibrosed lung border. Pneumothorax is often loculated due to formation of adhesions. In the upper half, compare the lung on both sides and the compression of the left lung will be clearly evident. This was a loculated pneumothorax. An after effect of a pyothorax is pleural thickening and in some cases pleural calcification. Note the irregular dense opacity in the right mid and lower zone. It is denser than the bone and is distributed irregularly. This is a typical shadow of pleural calcification. Note the extremely dense shadow which is sharply defined. If there is any doubt, a lateral or a tangential X-ray should be taken. The shadow of pleural calcification is seen to lie along the chest wall. This is another typical pleural calcification. It is a very dense and irregular sheet-like opacity with no fixed distribution pattern. Note the sheet-like opacity denser than the ribs with no fixed pattern. This is another X-ray of pleural calcification with dense irregular sheet-like opacity. Note in the close-up view its density, pattern and the typical appearance. Primary complex. Primary complex is a primary tuberculous infection seen in children. Radiologically, it shows two components, a peripheral parenchymal lesion and enlarged hilar lymph nodes. This is an X-ray of a primary complex. Note the increased density in the hilar region. Let's have a closer look. These are hilar lymph nodes seen as well-defined nodular dense radio-opacities in the region of the hilum in line with the parenchymal lesion. The blue arrow shows the parenchymal infiltration in the lower lobe. And here we see both the lesions together, the parenchymal lesion and the hilar lymph nodes. So, a primary complex has a parenchymal lesion and enlarged hilar nodes. The parenchymal lesion may sometimes be very small or resolved, and then enlarged hilar nodes is the only evidence of a primary complex. This X-ray of a child shows a primary complex with a small pleural effusion. Pleural effusion is more common in adult primary tuberculosis than in children. In a close-up view, note the two hilar nodes, then note the parenchymal lesion which defines the primary complex, and the vertical arrow shows the blunting of the right costophrenic angle due to a small pleural effusion. The next X-ray is an X-ray of a child with large hilar nodes on the right side shown by the blue arrow, and the vertical yellow arrow points to a parenchymal lesion. Now note the mediastinal widening. Presence of mediastinal nodes suggests that the primary complex has progressed to a post-primary tuberculosis. So one must look for mediastinal widening and widening of the carina. This X-ray shows hilar congestion on both sides with hilar nodes on the left side. Note in close-up view the dense nodular shadows of the hilar nodes and the faint parenchymal infiltration. This is an X-ray of the same child after 6 months of treatment, where the lymph nodes and the infiltration have both resolved. This is another X-ray showing hilar nodes on both sides. Note the rounded opacities at the left hilum. There is no parenchymal lesion seen. The right side also shows similar well-defined opacities of the hilar nodes. This is primary complex. Thoracoplasty. Before we end the section on tuberculosis, let me show you some X-rays of patients who have undergone thoracoplasty, which was a very common surgical treatment for upper lobe cavities before the advent of good chemotherapeutic agents. Note the absence of upper ribs on the right side. Thoracoplasty involved surgical removal of the upper 5 to 8 ribs, resulting in complete collapse of the upper lobe, which collapsed the cavity, rested the diseased lung, and resulted in a cure. This X-ray shows right-sided thoracoplasty. Note the absence of ribs over the right upper zone. The underlying lung appears normal. In a close-up view, count the upper ribs on the left side. We can see that 5 ribs have been excised. And note that the tuberculous lesion is cured. This is an X-ray showing left-sided thoracoplasty where 8 ribs have been removed. This is an X-ray many years after surgery, and you can see new bone formation from the periosteum of the ribs which is left behind. The calcification shown by the arrow shows how much collapse of the chest wall has been achieved by this surgery. Bronchogenic carcinoma. Whenever bronchogenic carcinoma is suspected, an X-ray of the chest must be taken first. A bronchogenic carcinoma arising from the main bronchus produces a dense homogeneous opacity in the region of the hilum continuous with the mediastinal shadow. In this X-ray, note the homogeneous opacity at the left hilum shown by the arrow. Note that its lateral border is not sharp, but it is spreading into the tissues. This is an important feature of bronchogenic carcinoma. Next, note that the left diaphragm is raised, indicating a collapse in the affected segment due to an obstruction in the bronchus. This is another X-ray showing a more advanced stage of the malignancy. Note the dense homogeneous opacity of the left upper lobe. In contrast with a consolidation or pneumonia, the left diaphragm is raised. It's higher than the right diaphragm, indicating a collapse of the lung. At the same time, the red arrow shows the trachea pushed to the opposite side, probably by the main mass or by enlarged lymph nodes, which will not be seen in consolidation or collapse. In the close-up view, note the dense homogeneous nature of the shadow and how it spreads into the neighboring lung tissue. This is another X-ray showing a dense homogeneous opacity at the right hilum. It is not related to any particular lung segment and is spreading into the lung tissue. In a close-up view, note its density and note that it does not have a sharp border. It is spreading into the neighboring tissues. This is a typical shadow of bronchogenic carcinoma. This is another X-ray showing a dense opacity at the right hilum. Any dense, more or less rounded and spreading opacity at the hilum should give a strong suspicion of a bronchogenic carcinoma, which should be confirmed or ruled out by bronchoscopy and CT scan. Incidentally, this X-ray also shows pericardial calcification shown by the red arrow. Note the dense calcific border of the pericardium. Now, there should be no difficulty in suspecting a bronchogenic carcinoma in this X-ray, where there is a dense spreading hilar shadow on the right side with elevated diaphragm due to associated collapse. Also note the healed fibrous tuberculous lesion on the left apex. We must, however, remember that a normal chest X-ray does not rule out bronchogenic carcinoma, and if clinical suspicion is strong, a bronchoscopy or CT scan should be done even if the X-ray is normal. So the essential features of a bronchogenic carcinoma are a dense homogeneous opacity overlying the right or left hilum. The opacity is not restricted to any particular segment or lobe and has a spreading border, and there must be evidence of collapse or infection, that is pneumonitis, of the affected segment. This X-ray shows a homogeneous opacity at the left hilum with diffuse haziness in the left lower zone. First note the dense hilar opacity shown by the blue arrow. The tumor causes partial obstruction of the bronchus and an impairment of normal drainage of secretions. So consolidation develops in the affected segment of the lung and does not resolve with antibiotic therapy. So this is a carcinoma of the left bronchus with consolidation of the left lower lobe. The corollary is that when a patch of pneumonia fails to resolve with treatment or resolves partially and recurs, an obstruction in the bronchus must be suspected. If the bronchial obstruction is complete, the affected segment or the lobe collapses. The atelectasis may be sharply defined, or if it is incomplete or mixed with consolidation, then its presence will be indicated by a raised diaphragm and crowding of ribs. Compare the upper zones on the right and left side. The faint opacity of the left upper lobe is appreciated on comparison. Also note the crowding of the ribs on the left side and the raised diaphragm, all indicating an associated collapse. Now in this X-ray, note the well-defined and roughly circular opacity in the right mid-zone, which is distinctly separate from the mediastinum. This is the typical shadow of a peripheral bronchogenic carcinoma. This type of malignancy may not be seen by bronchoscopy, and a definitive diagnosis will be made on CT scan or MRI scan. This X-ray of the same patient after 2 months shows a significant enlargement of the lesion. However, still you can appreciate that the main lesion is a distance away from the hilum. This is peripheral type of bronchogenic carcinoma. This is another case of bronchogenic carcinoma affecting the left lower lobe. Note the dense rounded opacity a little distance away from the left hilum. This is a peripheral type of bronchogenic carcinoma. For differential diagnosis, we should also consider other causes of a coin shadow, which we will be studying shortly. But note here the dense shadow with a spreading border in the left lower lobe. A peripheral type of bronchogenic carcinoma affecting the upper lobe, eroding and destroying the upper ribs, and affecting the brachial plexus at the root of the neck is termed as Pankost's tumor. Note the dense opacity in the right apex with rib destruction. The patient had presented with weakness of the right arm. This was a case of Pankost's tumor. Another common presentation of malignant lung neoplasms is a pleural effusion. Note this X-ray of a large pleural effusion. However, you will note that relatively there is no shift of mediastinum. Pleural effusion without shift of mediastinum should arouse suspicion of an underlying growth. The next X-ray after aspiration of 800 ml of hemorrhagic fluid clearly demonstrates the underlying tumor. Note the clear costophrenic angle after aspiration of the fluid and the dense hilar shadow of the malignancy. Once again, note this X-ray showing complete opacity of the right side. The important point to note is that there is no mediastinal shift. Complete opacity without mediastinal shift to the opposite side is very suggestive of malignant pleural effusion. Pulmonary metastases are typically spherical, that is rounded opacities termed as cannonballs or coin shadows. They arise from hematogenous tumor emboli which get lodged in the capillaries of the pulmonary circulation. This X-ray shows multiple but discrete round homogeneous opacities described as cannonballs. In the close-up view, 3 sharply defined rounded opacities are seen, typical cannonball opacities. This is another X-ray showing multiple cannonballs. Multiple rounded opacities varying in diameter from a few millimeters to centimeters are diagnostic of this condition. In close-up view, note the multiple metastases in the right lung and now in the left lung. Multiple rounded opacities may also be seen in conditions like multiple AV malformations or hematomas, lymphoma, rheumatoid arthritis, and fungal granulomas. This is one more X-ray showing multiple cannonballs. Note the large number of rounded opacities scattered in the lower zones of both the lungs. Sometimes a single large cannonball or coin shadow is seen. Note the coin shadow in the left lower zone. In the close-up view, You can see that it is perfectly round. It is sharply defined from the surrounding lung and does not have a spreading border like bronchogenic carcinoma. This is a metastasis. A single coin shadow may be seen in a single metastasis, primary bronchogenic carcinoma of the peripheral type, hamartoma or AV malformation, an abscess without air, a hydatid cyst, and traumatic hematoma. Secondary carcinomatosis. This X-ray shows both lung fields riddled with small opacities of varying sizes. This is termed as miliary carcinomatosis or secondary carcinomatosis. In contrast to miliary tuberculosis, here the opacities are larger, less numerous, they are not uniform in size, and they may be confluent. Compare it with the opacities in miliary tuberculosis, which are 2 to 3 millimeters in size, uniform and discrete. Once again, let us compare them side by side. On the right, the opacities in secondary carcinomatosis, which are larger, varying in size and confluent, while on the left, the opacities in miliary tuberculosis, which are smaller, uniform in size and distribution, and discrete. This is another X-ray showing secondary carcinomatosis. Note the large number of opacities, varying in size, many of them confluent with each other. They are quite different from the cannonball metastasis, which are very sharply defined and discrete. On the right, we see opacities of carcinomatosis, which are not perfectly round and the border is not sharp. This is another X-ray showing secondary carcinomatosis. Note the opacities, varying in size, confluent, and in large numbers. A variety of conditions may produce such miliary mottling, and a clinical correlation may be necessary. The common causes are infections like miliary tuberculosis, bronchopneumonia and aspiration pneumonia, and fungal infections like histoplasmosis and coccidioidomycosis. Then allergic conditions like tropical eosinophilia and Loeffler syndrome, malignancies like miliary and lymphatic carcinomatosis and leukemias, acute pulmonary edema, and miscellaneous conditions like rheumatoid arthritis, hemosiderosis, and interstitial pulmonary fibrosis. To revise, the common causes of miliary mottling are infections like miliary tuberculosis, bronchopneumonia and aspiration pneumonia, and fungal infections. Allergic conditions like tropical eosinophilia and Loeffler syndrome. Malignancies like miliary and lymphatic carcinomatosis and leukemias. Acute pulmonary edema. And miscellaneous conditions like rheumatoid arthritis, hemosiderosis, and interstitial pulmonary fibrosis. Lung abscess. The typical appearance of a lung abscess on X-ray is a circular opacity with an air fluid level in it and surrounded by diffuse hazy consolidation. Note the lung abscess in the right mid-zone with a fluid level shown by the red arrow. Only rarely is the abscess draining freely into a bronchus and has no fluid level. In fact, the presence of fluid level is the differentiating feature from a tuberculous cavity, which is almost always empty. Now this is a tuberculous cavity. A tuberculous cavity is more common in the upper lobe. It does not contain a fluid level, and the surrounding lung usually shows tuberculous infiltration or fibrosis. A lung abscess develops in a patch of consolidation, that is pneumonia. So at the very onset, we have a patch of consolidation, or there is a large segmental opacity without any fluid level. Then the characteristic air fluid level appears. Note the small air fluid level at the top of this patch of consolidation in the right middle lobe. This is an early lung abscess. Then there is the typical ring opacity, a thick-walled cavity with fluid level. The amount of fluid may vary from time to time. Then, as the consolidation clears, the wall becomes thin and the size of the cavity diminishes progressively. This is the normal course of events in a lung abscess. The differential diagnosis for a ring opacity with a fluid level would be number 1, a lung abscess, encysted pneumothorax, infected lung cyst or hydatid cyst, cavitating bronchogenic carcinoma, and a tuberculous cavity with fluid. This is an encysted pneumothorax, which is radiologically difficult to differentiate from a lung abscess. If the air fluid level is located peripherally, it is more likely to be an encysted pneumothorax. And if the fluid level is near the hilum with a dense hilar shadow, cavitating bronchogenic carcinoma should be considered. Now this diagram shows multiple small abscesses in the lungs. Multiple abscesses 1 to 3 centimeters in size with fluid levels is a characteristic feature of staphylococcal pneumonias. Emphysema. In this X-ray of the chest, note the increased radiolucency of the lung fields. The lungs appear more translucent and dark due to an increase in the air space in emphysema. Now note the low and flat diaphragms. The convexity of the dome of diaphragm is reduced and lies below the level of the 7th rib anteriorly. Now observe the intercostal spaces. They are widened. And lastly, the heart and the mediastinum has become small and vertical. These are typical features of an emphysematous chest. Now in the next X-ray, all the features of emphysema are seen. Hyperlucent lung fields with reduced vascular markings, wide intercostal spaces, low flat diaphragms displaying 8 ribs anteriorly, and thin narrow heart. In close-up view, note the dark lung fields with reduced vascular markings. Now in this X-ray, note the mediastinum and heart in particular. The heart is thin and vertical, termed as teardrop heart. Also, note the hypertranslucent lung fields, wide intercostal spaces, and low flat diaphragms. This is another X-ray of emphysematous lungs, shown for the low flat diaphragms. Note that the curvature of the diaphragms is reduced and they are almost straight. If right heart failure, that is cor pulmonale, has set in, then the right ventricle will be enlarged. Another feature of emphysema is formation of emphysematous bullae. A bulla is seen as a hypertranslucent shadow, just like a cavity, but with a very thin border, hardly noticeable on X-ray. Note the bulla in this X-ray in the left lower lobe, overlying the heart shadow partly. Note that it has no vascular markings and that it has a very thin border. This is another X-ray showing emphysematous bulla overlying the heart shadow. Large bullas may replace normal lung tissue and reduce the vital capacity of the lungs, resulting in severe breathlessness. Or the bullas may rupture, giving rise to a spontaneous pneumothorax. Note the pneumothorax on the right side shown by the arrow. The right lung is partially collapsed and features of emphysema are seen in both lungs. Note the wide intercostal spaces, very low and flat diaphragms, and a classical teardrop heart. To revise, the radiological features of emphysema are hypertranslucency of the lung fields, low and flat diaphragms, widened intercostal spaces, narrow teardrop heart, and formation of emphysematous bullae. The criterion for a flat diaphragm is the height of the dome of the diaphragm. Join the costophrenic and cardiophrenic angles by a straight line. Then join the farthest point of the diaphragm to this line by a perpendicular line. If this distance is less than 2.5 centimeters, then the diaphragm is considered as flattened. Bronchiectasis. Bronchiectasis is characterized by increased bronchial shadowing in the affected areas of the lungs, sometimes with multiple cystic areas. Note this X-ray of the chest with increased markings in both the lower lobes. A close view shows multiple cystic cavities in the medial part of the lower lobes, characteristic of cystic type of bronchiectasis. The cysts are very thin-walled and some may contain a fluid level when in the lower lobes. This is another X-ray of a patient who presented with chronic cough with copious foul-smelling expectoration. Note the multiple thin-walled cystic areas in the lower zone of the left lung. The cysts in dependent areas shown by the arrow contain a fluid level indicating retained bronchial secretions. A definitive diagnosis can, however, be made only on bronchography. This X-ray shows bronchial shadowing in the right middle lobe with multiple cystic areas. A close-up view shows several thin-walled cysts clustered together. There are no fluid levels. This is cystic type of bronchiectasis. This is another X-ray showing increased bronchial shadowing and a few cystic areas in both lower lobes. Observe in the close-up view the increased shadowing and a few cystic areas. However, for an absolute confirmation, it is essential to perform a bronchogram, which will also tell us the type of bronchiectasis and the extent and distribution of the disease in the lungs. In bronchiectasis, bronchi of one or more segments of the lungs are dilated and they are filled only up to 4 or 5 divisions as the distal bronchioles are occluded. Here we see a tubular type of bronchiectasis where the bronchi are uniformly dilated. There are 3 types of bronchiectasis seen on bronchogram: tubular bronchiectasis, cystic bronchiectasis, and saccular and varicose bronchiectasis. In tubular bronchiectasis, the bronchi are dilated uniformly and have parallel walls. In cystic bronchiectasis, the bronchi are dilated like balloons, giving cystic areas 1 to 2 centimeters in diameter. And in saccular bronchiectasis, the bronchi show areas of widening interspersed with constrictions, giving a varicose or corkscrew appearance. To revise, bronchiectasis is of 3 main types: tubular, cystic, and saccular, as seen on bronchography. On plain X-ray, there is increased bronchial shadowing, which may contain multiple thin-walled cystic areas. Pneumonia. The radiological feature of infective pneumonia is consolidation. In lobar pneumonia, there is a uniform opacity of a lobe or segment without any displacement of the neighboring structures like fissures, diaphragm, or trachea. Note the uniform opacity restricted to a single segment. This X-ray shows a uniform opacity of the right lower zone. The opacity merges with the heart shadow, hiding the heart border, indicating that it is in the right middle lobe. Note that it is bounded above by the transverse fissure, which is in its normal location. There is no displacement of the diaphragm or the mediastinum as would occur in a collapse. This is a consolidation of the right middle lobe due to lobar pneumonia. This is an X-ray of the left lower lobe consolidation. Note the uniform opacity of the left lower zone. The heart border is seen. It does not silhouette with the opacity, indicating that the consolidation is in the right lower lobe. There is no displacement of the mediastinum, so this is a consolidation of the right lower lobe due to lobar pneumonia. This is a close-up view of the left lower lobe consolidation, showing a very important radiological sign, that is air bronchogram. The arrows show the bronchi as radiolucent streaks contrasted against the opacity. Normally, the bronchi are not visible on plain X-ray of the chest, but in consolidation, when the surrounding alveoli are filled with fluid and become opaque, the bronchi become visible due to presence of air in them. The sign of air bronchogram is diagnostic for pneumonic consolidation. One must also know about the silhouette sign to be able to identify the lobe affected. Silhouette sign states that if two structures having similar radiographic densities are in contact with each other, that is at the same depth, then the interface between them is obliterated. But if they are at different depths, then they are seen as separate structures with their borders. In this consolidation of left lower lobe, the lesion could be in the lingular lobe anteriorly or in the lower lobe posteriorly. The hard border is indistinguishable, that is, silhouette sign is positive. The hard border in this area is an anterior structure, so the consolidation is anterior, that is, in the lingular lobe. While in this consolidation, the hard border is not obliterated, that is, a negative silhouette sign. So the consolidation is posterior, that is, in the left lower lobe. Applying this principle of the silhouette sign, if a consolidation of the left upper lobe obliterates the aortic knuckle, which is a posterior structure, then it is in the apico-posterior segment. If it does not obliterate it, then it is in the apico-anterior segment. The left hard border is anterior. So if a consolidation obliterates it, it is in the lingular lobe. If not, then it is in the lower lobe. The right hard border is also anterior. So if a consolidation obliterates it, it is in the right middle lobe. If not, it is in the right lower lobe. The domes of the diaphragm are in contact with the lower lobe. So if a consolidation obliterates it, it is in the lower lobe. Otherwise, it's in the middle or lingular lobe. This X-ray shows consolidation at two places. Firstly, in the right upper lobe, affecting the apico-anterior segment, and in the left lower lobe. In close-up view, note the uniform opacity characteristic of consolidation and the sharp delineation of the apical anterior segment lined by the transverse fissure below. The left lower lobe consolidation in close-up view shows a negative silhouette sign, that is, the hard border is clearly seen and the diaphragm is silhouetted, indicating affection of the lower lobe. Just next to the hard border, you can see a faint air bronchogram. This X-ray shows consolidation of the left apico-posterior segment. Note the uniform opacity and segmental distribution. It would be proper to remember here that this is the segment of the lung which is most commonly affected in tuberculous infections, and it mainly lies behind the clavicle laterally. In bacterial pneumonias, as the patient improves with treatment, the consolidation becomes progressively less opaque and resolves over 3 to 6 weeks. This X-ray shows a consolidation of right lower lobe, and the next X-ray repeated after 20 days shows a complete resolution. It is very important to repeat the X-ray every 1 or 2 weeks till complete resolution occurs. This is to look for two important pathologies. Number 1, development of a lung abscess, empyema or effusion. Note this partially resolved consolidation showing a air fluid level typical of a lung abscess. And number 2, if resolution is partial, there may be an underlying bronchogenic carcinoma with partial obstruction of the proximal bronchus. Note this dense hilar opacity in this partially resolved left lower lobe consolidation. Particularly, if there is a collapse associated with consolidation, bronchoscopy must be done to rule out bronchogenic carcinoma. Note again the uniform opacity of the lower lobe and dense opacity at the hilum. While evaluating consolidation, certain artifacts must be considered. Note the uniform opacity in the left lower zone. If you observe closely, a similar less dense opacity is seen on the left side. This is a soft tissue shadow of the breast. So the radiological features of consolidation due to infective pneumonias are a uniform dense white opacity affecting a single anatomical lobe or segment. It may show an air bronchogram if bronchi are patent, and silhouette sign with the borders of the mediastinum. It would be appropriate here to revise the anatomical representation of the lobes of the lung on a plain X-ray of the chest as seen in lobar pneumonia. On the right side, this is the upper lobe above the transverse fissure. This is the middle lobe merging with the hard border but not with the diaphragm. And this is the lower lobe merging with the diaphragm but not with the hard border. On the left side, this is the upper lobe. Its posterior segment silhouettes with the aortic knuckle. This is the lingular lobe merging with the heart border. And this is the lower lobe merging with the diaphragm but not with the heart border. Also, let us compare and note the difference between consolidation and infiltration. On the left is a patch of consolidation which shows a uniform white opacity limited to a single lung segment, while on the right is the typical infiltration showing a cotton wool like fluffy nature not restricted to any particular segment. In a close-up view, note the uniform white opacity of consolidation and the irregular patchy opacity of infiltration. That is the difference between consolidation and infiltration. Bronchopneumonia. Bronchopneumonia is a type of pneumonia where the infection enters through the trachea and bronchi and is aspirated into the alveoli, resulting in widespread patches of consolidation. This X-ray picture shows patchy consolidation which is not restricted to a particular lobe or a particular segment. Note in the X-ray that the mottled opacities are of varying sizes, mainly in the lower zone and more on the right side. This second X-ray shows mottled opacities in the right lower zone in a patient who had received general anesthesia. Aspiration is always more common on the right side, and hence aspiration pneumonias are also more common on the right side. Note the fairly large patches of consolidation, much larger than the miliary tubercles in miliary tuberculosis. The main differential diagnosis of large patchy consolidation is bronchopneumonia, acute pulmonary edema, secondary carcinomatosis, and fungal infections. Pulmonary edema. Pulmonary edema is a condition where there is left ventricular failure causing back pressure in the pulmonary veins and later fluid accumulation, first in the interstitial spaces and then in the alveoli. First, let us see the early changes. Initially, the upper zone vascular markings become more prominent than the lower zone vascular markings, which are normally prominently seen. The branching upper zone vessels look like the horns of an antler and is termed as antler sign. In the next stage, the interstitial edema appears. Blurring of the hilar vessels, especially the right lower lobe arteries, which is normally clearly seen, is one of the earliest signs. Then Curly's A, B and C lines appear in the lung fields, A at the apex, C in the central zone and B at the bases. Curly B lines are hair-like thin lines 1 to 3 centimeters long running horizontally above the costophrenic angles. They are the commonest to be seen. Curly A lines are similar lines in the apical and central zones situated midway between the hilum and the lung periphery and directed towards the hilum. Curly C lines are fine interlacing lines in the mid portion producing a spider web appearance. When the pulmonary edema increases further, there is alveolar edema, that is, air in the alveoli is replaced by fluid. This is seen on X-rays as consolidation. This consolidation is patchy and the opacities occupy mainly the mid zones on both the sides, the typical bat wing appearance or butterfly shadow. But more often, the distribution is not so typical but may occupy mainly the mid and lower zones and is usually more on right side. Now let us see the various changes on X-ray. Note the consolidation in both lower zones, which is patchy and more on the right side. Of course, if the patient lies in the left lateral position in the bed, then it can be more on the left side also. Such consolidation along with cardiomegaly is very suggestive of acute pulmonary edema. Now this is a very interesting series of 3 X-rays. The first X-ray, when the patient presented in acute left ventricular failure, shows a very severe degree of pulmonary edema with alveolar edema almost all over the lung fields. The second X-ray after 1 day of diuretic and digoxin therapy shows that the pulmonary edema has dramatically reduced.
The edema is seen only in the lower zones and there is a fluid collection in the transverse fissure on the right side. And the third X-ray after 5 days shows that all the alveolar edema has disappeared and there is only some remnant fluid in the transverse fissure which should soon disappear. Now let us come back to the second X-ray. This localized collection in the transverse fissure can easily be mistaken for a coin shadow like metastasis or peripheral bronchogenic carcinoma. But after diuretic therapy, as we saw, it vanishes within 2 to 3 days. So it is called as a vanishing tumor or phantom tumor. This is another X-ray showing cardiomegaly and an early bat swing appearance. Note the mid-zone consolidation on both sides plus upper zone involvement on the right side. This is pulmonary edema and a mitral heart. This is another set of two X-rays. In the first X-ray, note the cardiomegaly with patchy consolidation in the mid and lower fields. And the second X-ray, after 1 week, shows complete clearance of the lung fields. This rapid vanishing of the consolidation with diuretic therapy is another characteristic feature that reconfirms the diagnosis of pulmonary edema. Another place where the fluid may accumulate is the pleural space, more so on the right side. If there is a right pleural effusion with an enlarged heart, a left ventricular failure should be considered. If the effusion is bilateral, it will be larger on the right side. Note the right pleural effusion with cardiomegaly in this patient of congestive cardiac failure. Now we will have a look at the Curly's lines or lymphatic lines. Note this thin line in the mid zone. This is a Curly C line. And this horizontal lymphatic line 2 centimeters long above the right costophrenic angle is Curly B line. To revise the radiological features of pulmonary edema, the early changes are prominent upper zone vessels and blurring of the hilar vessels due to interstitial edema, and lymphatic lines or Curly ABC lines. Then the alveolar edema appears in the form of patchy consolidation of mid and lower zones and bat swing appearance. Then there is fluid collection in the interlobar fissures and in the pleural spaces. Pulmonary embolism. Pulmonary embolism, if small, may not produce any change in a plain X-ray of the chest. But larger emboli causing infarction of a whole segment or lobe produce a segmental consolidation and collapse. The changes are non-specific, but when related to the clinical situation, a diagnosis of pulmonary embolism can be made. This X-ray shows a segmental collapse in the right lower lobe. This was seen in an elderly patient suffering from deep vein thrombosis in his left leg who developed severe right-sided chest pain. The pulmonary emboli almost always involve the lower lobes. Note the wedge-shaped shadow of a segmental collapse. Now this is another X-ray showing a wedge-shaped consolidation in the mid-zone in a post-operative patient who developed breathlessness and hypotension on the third post-operative day. Note in the close-up view the wedge-shaped shadow of segmental collapse. If such a shadow is associated with pleural effusion, it is very suggestive of pulmonary embolism. This patient developed sudden breathlessness and severe hypotension on the second post-operative day following cholecystectomy. Note the collapse consolidation of the right upper lobe suggesting pulmonary embolism. The differential diagnosis will be aspiration or mucus plug obstructing the upper lobe bronchus, which was ruled out on bronchoscopy. The consolidation in pulmonary embolism is visible on the X-ray after 24 to 72 hours, and an X-ray taken immediately after the embolism will usually be normal, or it may show an area of reduced perfusion as an area of increased translucency. Smaller emboli may go unnoticed. but larger embolisms will give rise to segmental collapse, which is seen as a typical wedge-shaped shadow, and it may be associated with a small pleural effusion. Diaphragmatic hernia and eventration. This X-ray of the chest shows multiple coils of intestines on the left side. Herniation of the abdominal contents into the chest through the diaphragm is termed as a diaphragmatic hernia. In this X-ray, the hernia has pushed the heart to the opposite side and compressed both the lungs, causing serious respiratory embarrassment. In contrast, eventration of diaphragm is a developmental weakness or weakness due to birth injury to the phrenic nerve, where the hemidiaphragm, usually left, is weak and raised. Note in this typical X-ray of eventration the smooth round outline of the diaphragm with stomach bubble under it. In case of doubt, to rule out a lung abscess or a subphrenic abscess, a barium study should be done to demonstrate that the bowels are lying under the raised diaphragm. Eventration is often asymptomatic and may be detected later in life. This adult patient has developed tuberculous infiltration in his right lung, and the eventration of left diaphragm was an incidental finding which was initially mistaken for a lung abscess. Barium meal shows the stomach and intestines in the chest, confirming the diagnosis of eventration. Note the smoothness of the dome of the elevated diaphragm and the gas shadows and the fluid levels. This X-ray shows opacity at the right cardiophrenic angle with convexity upwards. This is likely to be a diaphragmatic hernia, as we saw in the section on mediastinal masses. A barium meal shows that the colon is herniating through the diaphragm and is lying in the mediastinum and chest, confirming that this is a diaphragmatic hernia. A lateral view shows that it is in the anterior mediastinum behind the sternum, that is a herniation through the foramen of Morgagni. Note again the plain X-ray appearance of the diaphragmatic hernia of Morgagni. Note the typical shape and note the gas shadows in it. This X-ray shows large gas shadows in the left hemithorax, pushing the heart to the opposite side and compressing the right lung. This is a large diaphragmatic hernia. Note the lateral view showing the colon rising into the chest. This X-ray shows eventration of the left hemidiaphragm. The diaphragm is raised and shows bowel gas underneath it. Now this is a post-operative X-ray of the same patient showing repaired diaphragm in its normal position. Compare it with the pre-operative X-ray of the eventration. This is another barium meal X-ray showing intestinal coils filled with barium in the left hemithorax, a diaphragmatic hernia. So the radiological features of diaphragmatic hernia are presence of intestinal coils in the chest, compression of the lung, and shift of mediastinum to the opposite side. A barium study is confirmatory. X-ray of the chest is a very important diagnostic tool in presence of chest injury. The various pathologies that may be seen on chest X-ray are fractures of the ribs, associated pneumothorax, subcutaneous emphysema, hemothorax, and lung contusion. This X-ray shows multiple fractures of ribs on the left side. When a rib fracture is suspected, each rib should be individually traced from its posterior end to the costochondral junction anteriorly. Any break in continuity of its border should be studied with suspicion. Here, the second and third ribs are fractured, and you can see subcutaneous emphysema or air in the subcutaneous tissues over the chest wall shown by the vertical arrow. This X-ray shows fractures of the 10th and 11th ribs on the right side. This X-ray taken in lying down position after a chest injury shows opacification of the right lung with obliteration of the costophrenic angle. Either a hemothorax or a lung contusion may result in opacification of the lung.
Uniform opacification of the whole side, more in the costophrenic angle, suggests a hemothorax, while in standing position, this would give a shadow akin to a pleural effusion. This X-ray shows surgical emphysema, which results from a pleural tear secondary to rib fracture and leakage of air into the subcutaneous tissues. Note the fibers of pectoralis major that are so clearly lined by the air, and the air in the subcutaneous space surrounding the chest wall. A careful inspection shows a small pneumothorax and border of the partially collapsed lung. This X-ray shows multiple fractures of the ribs. The 7th, 8th and 9th ribs are seen to be fractured. This X-ray shows fracture of the right 3rd and 4th ribs with subcutaneous emphysema, that is air in the subcutaneous space. So whenever you see an X-ray of chest injury with rib fractures, also look for pneumothorax, subcutaneous emphysema and pleural fluid collection. Mediastinal tumors. Mediastinal tumors are seen as a widening of the mediastinum, either on both sides or sometimes only on one side. Note in this X-ray the widening of the upper or superior mediastinum. Note the smooth borders of the opacity where it is meeting the lungs, and note that it is lobulated. Lobulated smooth margin is characteristic of enlarged mediastinal lymph nodes. When widening is bilateral, there can be no doubt about the mediastinal origin of the mass. In a close-up view, note the smoothness of the margin, lobulation and bilateral presence. Now in this X-ray, the opacity is seen on only one side. So we have to decide whether it is arising from the mediastinum or is it an opacity in the lung like bronchogenic carcinoma. 2 points help us to decide that it is a mediastinal mass. Number 1 is the smooth border. Even if the surface of the mass be irregular, the irregularity is ironed out by the 2 layers of pleura, whereas a higher opacity in the lung will never be so smooth. The point number 2 is the wide base towards the mediastinum. By completing the circle of the mass, it is appreciated that its major portion lies in the mediastinum. So the characteristics that differentiate a unilateral mediastinal mass from a lung mass are smooth border and a wide base, that is, the mass is more medially situated. Having come to a conclusion that the mass is arising from the mediastinum, we must now determine the compartment in which it is located, that is, whether anterior, middle or posterior. For this, we must take a lateral X-ray which shows the sternum anteriorly, the heart shadow in the center and the vertebral column posteriorly. The anterior compartment lies anterior to the heart behind the sternum, middle compartment is the heart shadow and the posterior compartment is behind the heart. In the anterior compartment, the common swellings in the upper third are retrosternal goiter, thymus and lymph nodes. In the middle third, thymus, lymph nodes and teratomatous dermoids. And at the cardiophrenic angle, pericardial cyst and diaphragmatic hernia. Now in the middle compartment, lymph nodes and carcinoma of bronchus are the common swellings. In the posterior compartment, the common swellings are neurofibromas, paravertebral abscesses, aneurysm of descending aorta and dilated esophagus in achalasia cardia. Now we will study some X-rays of mediastinal masses. Note this opacity in the upper mediastinum. It is bilateral and has a smooth border. It could have been a retrosternal goiter or a thymus if it was in the anterior mediastinum. But a lateral X-ray showed it to be located in the posterior mediastinum. It was a paravertebral cold abscess arising from this tuberculous lesion of the 6th and 7th cervical vertebrae. Note in the lateral view of the spine, destruction of the disc space and adjacent edges of the 6th and 7th cervical vertebrae, a typical tuberculous lesion of the spine. This was a mediastinal mass in the anterior mediastinum. In this region, it could be a thymus, a lymph node mass, or a teratomatous dermoid. This mass has a typical tiny notch shown by the arrow. This notch is typical of thymus. This was a thymic mass. Note the notch again. This mediastinal mass showing bilateral widening has a characteristic lobulated border, especially on the left side. This is a lymph node mass. Such large and bilateral lymph node masses are almost diagnostic of a lymphoma. Lymph nodes of tuberculosis or metastasis never grow to such a large size. I also have an ultrasound picture of this patient taken from the suprasternal notch showing the large and multiple lymph nodes surrounding the arc of aorta, thus confirming that this is a lymph node mass. Note again its typical lobulated border. This is a large mass filling the left chest of this child completely, so it is difficult to diagnose it as a mediastinal mass. But it is pushing the heart to the opposite side, which is unlike a lung tumor, and at the left apex its smooth border can be seen. Further, the mass shows calcification, which is characteristic of a teratomatous dermoid. No other swelling or shadow would show such calcification, particularly in a child. So this mediastinal mass is a teratomatous dermoid which arises in the middle portion of the anterior mediastinum. Now note this rounded opacity at the cardiophrenic angle on the right side. It is occupying the cardiophrenic angle and growing laterally. This is a pleuropericardial cyst. On lateral X-ray, it is seen to be anterior. This is the typical site and appearance of a pleuropericardial cyst. Note again the rounded opacity occupying the right cardiophrenic angle. A triangular hazy shadow filling the cardiophrenic angle suggests a pericardial fat pad. If the opacity is based on the diaphragm, it may be a diaphragmatic hernia through the foramen of Morgagni. And if the opacity faces laterally, then it is a pleuropericardial cyst. Note again the rounded opacity of pleuropericardial cyst. This is another X-ray showing mediastinal mass in the mid portion. The smooth lobulated border suggests it to be a lymph node mass. On lateral X-ray, it was occupying the anterior and middle mediastinum, suggesting a lymphoma. If such a mass occupies only the middle mediastinum, it suggests sarcoidosis. But if both anterior and middle mediastinal nodes are enlarged, it is more likely to be a lymphoma. Now in this X-ray, follow the shadow of the trachea to the carina. Note that the carinal angle is widened. First note the widening of the superior mediastinum. Note on the left side the lobulated smooth border of these enlarged lymph nodes. Now follow the shadow of the trachea to the carina. Note that the carinal angle is widened. This widening of the carinal angle due to enlargement of subcarinal lymph nodes is typically seen in tuberculosis. So these are tuberculous lymph nodes in mediastinum. Now note this characteristic shadow on the right side of the mediastinum. It extends from the diaphragm to the neck. It has a smooth outer border shown by the red arrow, and it has a fluid level shown by the yellow arrow. This is a dilated esophagus in achalasia cardia. On lateral X-ray, it will be seen to lie in the posterior mediastinum behind the trachea and the heart. This is the typical shadow of a dilated esophagus on the right side with fluid level in achalasia cardia. Note this mass in the upper third of the anterior mediastinum on the right side. It could be a lymph node mass or a thymus or a retrosternal goiter. You cannot give a definite diagnosis. Remember that mediastinal masses are visualized much better and diagnosed more accurately on a CT scan or MRI scan, and that is the investigation of choice once a mediastinal mass is diagnosed on a plain X-ray.